Always fun to play the game of am I live or am I not? Hey, there we go. Looks like we are in fact live. Awesome. All right then. Since it looks like things are mostly working, we'll get started. My name is Mike Hess, and I am the chair of the American Association for Respiratory Care Ambulatory and Post-Acute Care Membership Section, and this is office hour. This is a time for people in the RT community or interested in the RT community to come together and ask questions, provide some input, provide some suggestions. One of the biggest complaints we hear is that we in leadership roles don't always connect with a lot of the people out there with concerns and everything else, and so this is my effort to try to change that. Let's see here. We'll get things rolling here. Well, we've got a couple of different ways you can participate. It looks like a couple of them are also being a little quirky again this time around. We tried to do this. Oh, hey, there we go. We are on YouTube now. How about that? We've got a YouTube channel going for the ambulatory and post-acute care section. We are here on LinkedIn, and we have a Zoom window, as you can probably see there. We'll put the link in that to the chat. Copy that and paste. Too many windows open. There's where we want to paste it. So you can join, again, you can join right into the Zoom and interact with the conversation, or you can just check things out here on LinkedIn or YouTube. So, Kathleen, welcome. How are you doing today?
I'm doing well, thank you. How about you?
Awesome. I'm a little cold. I'm here in southwestern Michigan, where it is a balmy 18 degrees right now. As
I see. Boise's at. We got above freezing finally. So hey, we're at 34. It's been real cold and snowy here.
We were up there about a week ago, and then we had our latest winter weather event was yesterday or the day before. Got about 4 or 5 inches, and we're supposed to get another 2 to 3, I think, tomorrow. So winter's last
We have
hurrah.
more incoming as well, so I'm there with you.
I know a lot of the country is facing a lot of that, so I hope everybody is staying warm, staying safe, and all that good stuff. It has been obviously a wacky weather year already, and it's we're barely 6 weeks in. So, all right. Well, Kathleen, you have anything interesting going on in your neck of the woods out there in a respiratory perspective that you want to share?
Well, yeah, I will. This is more related to Alpha 1 and COPD, but we're under the same umbrella in my world. We have a brand new meeting starting up in the Seattle group area, and that our first meeting since COVID is going to be April the 12th. So pretty excited about that.
Yeah, absolutely. If somebody is in the, I'm sorry, you said you were in Idaho?
I'm in Idaho, but the group is in Seattle. I'm the group leader for the Seattle area. Yeah. So
how would somebody, if they wanted to participate in that, how would they access that or sign up for it?
Actually, it's going to be sent out to anybody that we know is an alpha. From the Alpha 1 Foundation.
Oh, excellent.
And then there's a response there and all the information and how to get involved. Absolutely.
Great. So they can go to the Alpha 1 Foundation and sign up for that?
Yep, absolutely. Awesome. It won't be ready yet. It should be probably publicized in probably next week. Yep. But I'm pretty excited about that.
Yeah, that's fantastic. I'm a huge believer in the power of support groups, especially peer support groups. So, and I know I've been seeing a lot that flu is real rampant right now and all that. Hopefully, that'll die off a little bit before April. But I'm a big believer in.
If so, I'll be there with mask on.
Yeah. I'm a huge believer of the in-person meetings because, as much as great as stuff like this is, Zoom and everything, first of all, I think we've all had a little bit enough of that over the last few years. But also, there's just, again, something about having that face-to-face contact. It's been,
Absolutely. And the wonderful thing is, I don't know if you know who he is, but Dr. Oliver McIlvaney, who's now at University of Washington, is going to be our very first speaker.
oh, great.
And and I just feel so amazingly happy that he's going to be there because he has such a wealth and breadth of knowledge, and he is so easy to talk to. And people that have alpha 1 and have, pulmonary issues, he's just there. He's just amazing.
That's great. That is fantastic. So, anybody else who might be watching this, if you have an event that you want to share, either, again, you can drop it in the chat. You can let me know via LinkedIn, via my email address, mhess@copdfoundation. Or excuse me, I'm supposed to use my civilian email for this. mhessrrt@gmail.com. And be happy to try and promote that through whatever channels I can. I chuckle a little bit, but there have been some folks who are like, "Well, is this a COPD Foundation meeting? Is this a AARC meeting?" So I'm trying to do a little bit better job at more explicitly slicing the line there. So mhessrrt@gmail.com. All right. So one thing I also like to do with these is, as we're waiting on questions or waiting on some other participation, I love to share some of the latest news that's going out. And this is actually this. I feel that this is potentially going to be a big year for oxygen. Oxygen therapy is one of my main gigs at my day job in the foundation. And of course, a big point of emphasis for a lot of the folks in our APAC umbrella with DME and home care and pulmonary rehab and everybody else. And as many people know, as many people are aware, obviously, oxygen therapy in the U.S. has been challenged over the last couple of decades now at this point. And we're seeing that around the world too. We saw a lot during the pandemic where resources were strained and everything. But now as countries have tried to recover from that and are also starting to build out some of the chronic care infrastructure to go along with the acute care infrastructure, we're seeing a lot of need for development. And so it is definitely getting a higher profile internationally at a global scale. And in response to that, there are a couple of things happening this year that are really going to support that. The first of which is actually coming up next week. And I have a link for this. Here we go. The Lancet Global Health Commission. If you aren't familiar with the Lancet, it is a very well regarded medical journal, and they periodically have these special commissions that look at global health issues. A few years back, they had one that was looking at redefining and recategorizing COPD. Trying to look at how we manage that more than beyond just spirometry and things like that. And the most current one has to do with medical oxygen access or medical oxygen security, sometimes they call it. And after about 2.5 years, the report is finally ready to be launched. And I just put a link in the chat where you can actually sign up for that. Now, admittedly, it is fairly early in the morning. It kicks off at 11 a.m. Greenwich Mean Time, which here on the East Coast is about 7 in the morning, I think. I think we're GMT -4 right now with daylight savings, but so it's a little bit early, but it will be recorded, and a lot of the resources will be available to discuss that. And so what this particular document is going to cover is, again, it's mostly going to cover on the acute care space as countries start to build up that infrastructure, make sure their hospitals have the right equipment, the right knowledge to provide oxygen therapy in the appropriate manner, all that sort of thing. But there is a companion piece that will be coming out. I don't know if that's also launching the 18th, but it will be coming out soon that takes a look more specifically at long-term oxygen, because that was recognized as an issue, although there's a lot less evidence and data out there for that because, again, these low and middle income countries, low resource areas, the focus has been on actively keeping people alive rather than, that quality of life stuff that goes with chronic hypoxemia. So That's kind of the next step to it is looking at that long-term stuff. So this Lancet Commission report opens the door to that, and then obviously looks at how do we address these in clinics, in hospitals, all that sort of stuff, and then moving forward, how are we going to do a better job with that over the long haul? In I guess arguably the next piece of that is about the week after, where there's about, I think we've identified 4 or 5 different organizations, including my employer, the COPD Foundation. We're going to be down in Washington, D.C. On Capitol Hill, promoting the reintroduction of the Supplemental Oxygen Access Reform Act, or the SOAR Act, which was something that we tried to get together in the last Congress. Unfortunately, we couldn't quite get it across the finish line by the end of the session. So it all has to be reintroduced now, but there's still a tremendous need for it. And so we're going to be there. The Pulmonary Fibrosis Foundation also is there that week. Actually, the American Association for Nurse Practitioners are going to be looking a little bit more on the pulmonary rehab side of things, but they're going to be there. I believe the AAC VPR is also going to be there. There's about, like I said, 4 or 5 groups, all going to be talking to Congress, trying to get these things reintroduced. Overall, there are about 3 dozen different advocacy organizations that are working on SOAR Act efforts. So, exactly when it gets reintroduced, it's hard to say, but we're still maintaining the fight to do that. So, and Kathleen, you're going to be there. Excellent. Are you with the COPD Foundation or one of the other groups?
Yeah, I'm a brand new captain, state captain.
Oh, excellent. Cool. Well, hopefully.
I'm excited. I was there last year too.
Oh, okay.
Just as a patient, and now I just got more involved.
Awesome. Well, we'd love to see that, and hopefully your flights go well and everything, and we'll make sure and reconnect while we're there. And then let's see. On the oxygen side of things, there's also the United Nations. They meet pretty much every year, I think, off and on. But every few years they have what they call their high-level meetings on various topics. And this year they're having a high-level meeting on non-communicable diseases. So things like COPD, asthma, all that sort of stuff. And we are working hard to get oxygen on the forefront of that agenda. And, really, again, trying to get stakeholders and health departments and everybody else around the world to really look at this as an important issue, because it's one of those things that has gone overlooked for a very long time. Similarly, I actually was just on a webinar yesterday that was, let's see, their official description is showcasing oxygen scale-up initiatives to complement and support partners and member states in their efforts to develop national medical oxygen scale-up plans. And so again, what that's saying there is, we look at the continent of Africa, for example. There, I think at the beginning of the pandemic, I want to say there were 3 main oxygen generation plants for the entire continent. And so obviously that was a real strain to their infrastructure. And so in response to that, a lot of countries have been saying, well, how do we do that? Well, what are the investment points? How do we operationalize some of these things? And so this webinar is part of a whole oxygen-oriented series done by the World Health Organization to try to help countries do that. Now, here in the U.S., that's not as much of an issue necessarily looking at that kind of infrastructure, but it's really good to have these connections too, because there was a lot of discussion, particularly on this call, about it takes a lot of energy to condense oxygen, to distill oxygen. There are a couple of different ways to manufacture it in bulk, and it takes, regardless, it takes a lot of power. And again, these electrical infrastructures are often a little shaky and not necessarily up to the task. And so a lot of people were looking at, we're asking, how do we maybe leverage solar power, on some of these generation plants? And that's a great idea. And there are actually some developing technologies for that. But that doesn't mean that that's not applicable here. We talked about there being some wacky weather already this year. The wildfires in California. At the end of last year, we had all the hurricanes that went through Florida and even up into North Carolina, and they're still dealing with a lot of those repercussions. solar powered oxygen concentrators and solar powered generation plants at a larger scale would be fantastic for those kinds of responses. And so what may be, it may not necessarily be a one-to-one application going from one country to another, but there are certainly ways that we can look at that here in the U.S. So it's really good to keep an eye on some of these developments. And then as I was looking at the resource, so you can actually get some more information for that and watch the webinar if you're interested. It was about an hour and a half long. Put the link there. And then there are also a couple of other oxygen scale-up events. There's a whole workshop series that talks about different aspects of creating these projects and funding these projects and everything else, at the international scale. So if anybody is interested in, again, these larger scale oxygen initiatives, I invite them to certainly check out the WHO and the Lancet Commission and all these other groups that are working to do that. All right, let's see what else we've got here. So turning our attention a little bit elsewhere into some latest respiratory news, which is another thing I like to try and cover on some of these. A new article came out, actually just published today, on heliopulmonology. Looks like there was a study came out in the Journal of the American Association I can't ever say that word. Otolaryngology. There we go. Head and neck surgery, it says. Pediatric patients with severe obstructive sleep apnea and vitamin D deficiency were actually had more severe sleep apnea than those without the deficiency. And so it's been interesting to look at the evolution of this over the last, let's see, before I was at the foundation, I was in primary care for a few years and worked on COPD before that. So we're probably looking at about the last decade or so where I've really been focused on COPD and looking at how vitamin D can affect exacerbation frequency and all that sort of thing. And so it's interesting to see where that's evolving into some other conditions as well. So, I don't talk a lot about pediatric stuff. Never really been a peds guy, but it's, again, if we're looking at making sure that people have the appropriate vitamin levels, that can impact a lot of disease states and can be an issue. Again, in these northern latitudes, especially in the wintertime, it can be tough to get the most amount of vitamin D that you need. So Kathleen, I think you said you had something you did actually want to bring up real quick.
Well, it's something that I don't know if it applies or how many people it would apply to, but because I've mentored people in a peer group situation for pulmonology, because it was so amazing for me, I have found when I'm mentoring people that one of the things that they don't come out and say until you do some, really active listening and motivational interviewing kind of techniques, they don't ever say, well, hey, I'm not really that involved, or I'm not really going to do much because I did this to myself because I was a smoker. And I'm really interested in finding out how we can take that very down approach and turn it around so that they become active participants in their health and in a support group and in a mentoring program, in coaching in any way, shape, or form. That's something that I'm just interested in if anybody else has seen this, experienced it, understand the psychology behind it, but they just don't get involved in their health. As I would expect anybody to be honest with you, I was pretty proactive, and so I have a real difficulty understanding why some people aren't, and that's a journey and a trip I'm taking and trying to go in my understanding. But I would just like to know if anybody has ever discussed this, has studied it, has anything.
I don't think there's a lot of research out there. I think it's a relatively new, I shouldn't say it's a new idea because obviously we've known that this has been an issue for a long time. I would I would argue it kind of stems from a lot of the clinicians out there. Because, well, why didn't you stop smoking? Well, why haven't you done this? Why haven't you done that? Um,
That's the second part of it is pulmonologist. And again, I have a separate bandwagon for Alpha 1. 6% of pulmonologists test for Alpha 1 for somebody who has COPD. 6%. Because they have sometimes smoked. And yes, that precludes Alpha 1. I mean, if you smoke, you're doing this damage to your lung, yourself, but that doesn't mean that there aren't some other bigger picture items that you need to look at as well.
Oh, absolutely. And I'll talk to that first a little bit because that's been part of my own evolution. I knew very little about Alpha One, even before joining the COPD Foundation. I knew it was underdiagnosed. We can throw all the numbers around. 1 in 10, and take 6 years to from symptom onset and all that sort of thing. But I didn't realize a lot of the issue, and some really good points have come up. Since I've been working in some of these projects that are kind of parallel or tangential to Alpha One. I think it's a really good point that so if somebody presents as a smoker or as a former smoker and they've got COPD related damage and all that, most people aren't necessarily going to think of Alpha One. But what about the families of all those people? Then we start getting into
exactly
into genetic testing and and counseling
yes.
and all that sort of thing.
Yes.
And that doesn't necessarily mean that the Alpha One deficiency shouldn't be treated. I mean, maybe that person is still a candidate for augmentation therapy, and I think it's just one of those things where there's that saying where if you hear hoofbeats, you should think horses, not zebras, because 90% of the time it's a horse. But I think sometimes we really do swing too far the other way, and we never think of the zebra, even though it could very well be. And the opportunity cost of actually doing the testing and the screening and all that these days, in particular, is so small. I mean, it's a the cheek swab. Yeah,
it doesn't take that much, right? But I think also there's that whole concept of, well, you were a smoker, why should we?
Yeah, exactly.
And my answer is because of my family. I found out I was Alpha 1 because of the COPD Foundation.
Oh.
Because my pulmonologist didn't test me. But on the COPD Foundation, they had all this stuff about genetic COPD and referenced Alpha 1. And I remembered that, hey, my dad died at 53 from emphysema. That's fairly young. Maybe I should get tested. And so I sent it in through the COPD Foundation. So yay, COPD Foundation, for being a big brother there and having that on there.
Well, and that's another thing that, as I was talking with some of the alpha representatives, again, when I was in primary care, even before my current job, they brought up some good points of, everybody, it's easy to find those people who are, it's the 25-year-old with the lungs of an 80-year, the extreme, the outlier cases. But, what about those people that are, 40, 50, 60, and, now they're starting to see symptoms. And I saw, this was probably about 2017 or 2018, saw a really good presentation by a guy by the name of Len Geiger. You may know, he does a lot of presentations around the country. And he talked about how he had been told it was asthma and it was no big deal, and his whole family has asthma and it's not, any kind of thing. And he was one of those people that took like 6 or 8 years, and then finally, like he saw a thing and was like, well, hey, can we test for this? And sure enough, it was, an Alpha 1 deficiency. And, we just, again, get caught up in looking for the obvious cases that we miss what shouldn't be obvious, but we miss easy catches. I'll say that. Going back a little bit, I did find there was a study. It looks like this was published in 2021. That was a review of some of the research projects that were out there. Again, this kind of speaks to exactly how early days we are in this kind of research, because it says Substantial evidence documents processes, moderating factors, and individual/social community responses to the complex phenomenon of COPD-related stigma. So, I mean, they're basically saying, yeah, there's a lot of evidence for it, but the prevalence of that stigma and its health effects are unclear. So, acknowledging that this thing exists, but now we have to do something with that knowledge. What are those impacts? How many people are there that say, well, I'm not going to talk to my provider about this because I know it's a smoker's cough and I shouldn't have done it, and there's nothing they can do about it anyway, so why bother? I've got more important things. And I think that's really important thing. And also, I found this other article about the same time from The Lancet, actually, that talks about stigma being an unmet public health priority in COPD. And it goes into a little bit more detail than that, but again, even with some of the language, as I'm skimming the article here, the use of outdated and derogatory terms when talking about patients, like we used to use the terms blue bloater and pink puffer to distinguish between emphysema and COPD. Probably shouldn't do that anymore. Hopefully we're not doing that anymore, but I do see that pop up from time to time. But yeah, just trying to get this information out there. Now, I will say, let me see if I can find a link to this real quick. There is a new tool that was released a little bit earlier. I guess it was toward the end of last year, officially introduced in the end of October through an organization called the Global Allergy and Airways Patient Platform, called the COPD Care Map. And again, this speaks mostly toward conventional or traditional forms of COPD, I suppose. But I think a lot of the concepts in it are valid because it talks about the experience. It's a little bit more of a storytelling tool that can be adapted to do presentations for policymakers or for public health events, all that kind of stuff that happens. And so I think some of this in there does talk a little bit about stigma, and it's got interviews with folks, and it has instructions on how it can be localized to different parts of the world, because obviously this is the global platform. But and start having some of these harder conversations, and instead of saying, well, yeah, you're right, you shouldn't have smoked, maybe have the conversation of, well, okay, you smoked, and that is what it is, but what are we going to do going forward? How do we address that? How do we address where you're at instead of where you've been?
I have probably something that's way offline as far as an example, but I'm going to use it because it belongs to me anyway. I was a rabid skier as a youngster, and I broke my ankle and my leg, and I broke my ankle again, and I did a lot of things that racked my body up that I'm now paying the price for. But nobody ever said, well, if you hadn't skied, you wouldn't have this and this and this and this and this. Nobody says that. There's no stigma attached, but I did it every single time, but with COPD, and it doesn't seem to matter what form of COPD. The whole concept is, well, you did it to yourself, so why should we care? And that's what it feels like sometimes. And, some people, myself included, are just going to go, well, first time I researched COPD, the first thing I read was 5 years. That's it. And, we all know that that's old and untrue statement. For 99% of the people, you have more than 5 years. But that with that first response, you get that, and then you could go down because I did this to myself. I'm just going to have to deal with it, and I'll just be quiet and, da 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 da. Or you could say, okay, what can I do to help myself? And I want to make that what can I do to help myself much more prevalent than what I have seen. That's what I want to achieve, So that's what I'm looking for in the research and in the discussion.
Well, I think we can also take a page from the the diabetes or metabolic medicine world, because one of the stories I would always share with people, and I still do, I was never a smoker, but I was a snacker. I struggled with weight my entire life. I was always in the husky section as a kid and, doing all that kind of stuff. And I ended up at one point weighing about 360 pounds. And I would get a very similar thing. It's like, well, all you need to do is eat less. All you need to do is move more. You should go do this, go do that, go for a walk, join a gym, all that. And, obviously we know it's not quite that simple. Um, and now that we have some better tools, all the medications that have come out, and we're starting to have a little bit better of an understanding of the complexities of it. We're starting to move a little bit past that. Now, I say starting because we still have a long way to go, because people are still looking at some of these drugs as shortcuts and everything else. And I can tell you, as someone who has been on the meds, actually back on the meds, and also had bariatric surgery, none of it is really a shortcut.
Yeah.
It's not a miracle drug in the sense of what we usually think of it as. Well, you just take this pill and you're fine. It's not that at all. It changes a lot of lifestyle issues and everything else. So there's maybe some new stigmas that are coming out, or new misconceptions, but I do think we're moving along the path toward okay, we have some real issues, and as we're trying to figure out how to fix those, let's change that conversation a little bit more. And again, when I was in my lead up to the surgery, the medications were fairly new at that point and were a big part of that, because they kind of help you learn better habits, in order to make those true changes. Sure. And, again, I think that's what we need to look at. That's the approach I tried to use with tobacco cessation. We often look at it as, we got to set a quit date, you got to do this, you got to do that. And that works for some people. But there are those who, they'll set a quit date and they won't achieve it. And then they'll feel bad, and then they'll say, well, what's wrong with me? And then they'll go back for their next checkup, and the doc will say, what's wrong with you? Or the clinician. I'm not trying to throw docs under the bus. And then that whole cycle repeats, where it's like, okay, first of all, let's set a realistic goal. A month from now, can you cut your smoking in half? If you're a pack a day, can you go down a half pack a day? And start building those habits and changing habits, where instead of, every time you're stressed, you go for a cigarette, you go for a walk, or you chew some gum, or, I would give people like cinnamon sticks, or toothpicks, that kind of stuff. You work on some of those, the neurological side of things, rather than just, changing the one vice. Seemed to work. Again, I don't have a lot of evidence to definitely say it worked, but I think that's where we need to be with a lot of these conditions.
Thank you for that. I appreciate it.
Yeah. And interestingly, that was one of the news articles I had popped up in the queue here. Was speaking of diabetes medications. Certain glucose-lowering drugs were linked to fewer moderate or severe COPD exacerbations in adults with type 2 diabetes. This is another one that comes out of the Journal of the American Medical Association. So they were looking at SGLT2, it's one of the hormones. GLP-1 receptor agonists, those are the really famous ones right now, the Ozempics and everything else. And DPP-4 eyes, which I think that's just another one of the hormonal biological kind of things. And this is really important why I clarified they're not a miracle drug in the conventional sense, because the more we find out about these, yes, there are some things that maybe we haven't seen all of the downsides. Like I saw an article yesterday that there were some folks that had some vision changes and stuff that were previously associated with rapid drops in blood glucose, but are now being associated a little bit with some of these meds, needing for future study. They really have had a lot of impact in disease processes outside the metabolic system, Alzheimer's disease, a lot of inflammatory processes. And that seems to be what we're seeing with this article, led to a decrease in COPD exacerbations, for SGLT2s, reduced bronchial hyperresponsiveness in DPP4s, and improved forced vital capacity in GLP-1s. Now, they do say that these are observational studies, small sample size, some of that stuff. But again, this is where a lot of research starts. So this is now where we go and we say, okay, well, we're starting to see this signal. Maybe we should pursue this a little bit more. So it's interesting to see where some of these things can really all tie together. Hopefully, we will see continued research go on with that. I'm, again, not trying to get too political or anything, but research is really an essential component to healthcare. And I will say that I'll go political enough to say a lot of the policy decisions that are starting to come out of the government in the U.S. right now are not necessarily aligned with keeping our place as a global healthcare research leader. So hopefully we can see some changes with that, especially as we get into some of the other lobbying and advocacy spaces. Hopefully that threads the needle well enough. All right, another thing I want to highlight a specific respiratory therapist. Actually, this is really cool because this is somebody I know. This is somebody from here in Michigan. She has done a lot with our education programs here in Michigan. I'm going to drop a link into the chat again here. Was recently highlighted by one of our local news stations because she was attending a high school basketball game, and a referee had cardiac arrest on the court. And fortunately, Angie Prush was there to do CPR and get the AED. So this link that I just put in there is coverage of an event where she was honored by I think the city. I guess at the high school. I think everybody got a certificate here. Thursday night in Jefferson High School in Monroe County, referee Doug Sanders got a special honor along with the people who helped save his life during the game back in November, including first responders and a respiratory therapist who happened to be right in the stands that night. As soon as I got to the court, the first thing that I wanted to do was check for the pulse, which I did, and everyone else started coming in at that time, which was wonderful. We all worked together, and when we didn't have the pulse, I started compressions while others called 911 and got the AED. Angela Prush, who performed CPR that night, said. She does, as I said, fantastic work with our education department, and it's always nice to see RTs getting celebrated for the things that we do, whether they're in the hospital or outside the hospital. So, Angie, if you happen to be catching this at some point, or if somebody wants to pass it along to her, I'm sure I'll see her again before too long. We've got our state meeting coming up in a couple months. Congratulations to her, and thank you for being such a excellent example of our professionalism in our career. And then one other news item I had that was just kind of a fun one. Back to oxygen-related news. We have out of looks like this is out of Philadelphia suburbs. First responders in Bristol Township in Pennsylvania were able to save a pit bull from an early morning house fire on Thursday. And then after the rescue, the firefighter administered oxygen to one of the dogs until it regained consciousness. And it turns out that the oxygen masks used for this were donated by Emily Rilling, a Middletown teen who in 2018 used her 12th birthday money and some crowdfunding on Facebook to donate masks to emergency responders across Bucks County. This teen was able to raise more than $3,400 to purchase dozens of masks for small, medium, and large dogs, and then distributed that to the fire department, and were put to excellent use. So again, always, as I like to say, everybody needs oxygen. Some bodies need a little bit more, and that includes our pets and our animal friends too. So well done to everyone involved in that story as well. All right, so that takes us to about 15 minutes to go, usually in the hour here. Got a few viewers out there, so appreciate everybody stopping by here, especially on Valentine's Day. Um, Although it's probably a little bit early in the day for most people to really get into the exciting parts of the day, but at any event, really appreciate everybody coming by and checking out the latest news in the respiratory world. Let's see if we can find anything else that is exciting here. I was wondering if this would actually go off because I usually like to do some reminder posts on here and then also on our AARC Connect platform, but just did not have time to do that this week. Well, in general respiratory news, well, that's not good. Pope Francis was hospitalized on Friday after a week-long bout of bronchitis worsened and he was receiving drug therapy. Best wishes to the pontiff. Hopefully he can have a full and safe recovery before too long here. Being treated at a hospital in Rome. Having some breathing difficulties, so hopefully again he's getting, whether it's oxygen or antibiotics or whatever it is, hopefully he's getting the care that he needs. And let's see, we've got some other less super positive news. This is seems like it's shaping up to be an intense flu season. Well, that had a paywall there, so let's see if we can find where are we at for flu rates. Here we go. Flu deaths may have surpassed COVID deaths nationwide for the first time since the start of the pandemic. Nearly 1.7% of all deaths, nationwide in June for the week ending January 25th were the result of the flu. More than flu hospitalizations were more than 3 times higher than COVID hospitalizations. This is a nasty flu season right now. So, which is really exciting as I'm getting ready to fly to Dallas for the MedTrade conference next week. I guess I need to get myself some more N95s. So those of you who are, first of all, those of you who are in and out of the hospital, please make sure that you're taking care of yourselves, but also in and out of patient homes, in and out of grocery stores, wherever you're at, just make sure that you are, masking up as appropriate or, taking other precautions, just making sure that you're keeping yourself safe because, again, this is a nasty one. And from other, again, I don't know that I have a definitive source on this. We're not necessarily looking at, all of these are bird flu or anything like that just yet. I do know that there are some states that are trying to do a better job at some of the serotyping and things like that to see if there are some forms of the virus that have popped over from the birds and the cows and everything and are starting to be a little bit more impactful to the human population. But then it does say that flu shots have been lagging a little bit, so not too late, I don't think, to get your flu shot. Don't be afraid of your flu shot. It's not, contrary to popular belief, it's not necessarily 100% going to prevent you from getting the flu. But even if you do get the flu, it generally does make it less severe. So please go ahead and get your flu shot and get any other vaccines that are appropriate for your age group and condition. Again, not too much of a soapbox there, but let's just use some common sense. Okay, I'll go back to pulmonary news. Anything else really exciting? Otherwise, we may just call it a few minutes early here. A couple of drugs that are popping out for coming close to their endpoints of their studies, but it looks like other than what we've talked about so far and some of the news coming out in the oxygen space, looks like it's been a somewhat quiet week on the pulmonary front. So I think we'll call that a day then. Again, really appreciate anybody who came out and was watching all or part of the show today. Kathleen, thanks for joining us on Zoom. Really appreciate you stopping by, and that was a really great conversation we had about guilt and stigma and COPD and related conditions. And really good to hear about the support group that you're going to be running in Seattle coming up in April. So, again, anybody out there who has some other events or some other news that they'd like to see on here, this is definitely happy to help with that as much as I can. mhasrrt@gmail.com or right here through LinkedIn. Send me a message. Not hard to find on other channels as well, including AARC Connect. I will highlight that next week we also do have our ambulatory and post-acute care membership section meeting. Which is a monthly meeting. We'll be promoting that a little bit as well. That'll be on Zoom. We'll get some links out there. So whether you are a member of the section or not, we do invite anybody with an interest in the ambulatory and post-acute care world to come out, and we're going to have a guest speaker from the long-term acute care world talking about the role of respiratory therapists in that aspect. And we'll talk about the rest of our goals for the section going on through the rest of the year and into 2026. So until then, again, happy Valentine's Day. Take care of yourselves, take care of each other, and we'll see you next week.